Hello, I'm Yael Maxwell here at ESC 2015 in London, England. I'm here talking with Dr. Spencer King of Emory University School of Medicine in Atlanta. He's also the editor of JACC, Cardiovascular Interventions. Thanks for being with us.
Glad to be here.
So one of the first trials I want to talk to you about is the BACK trial, which looked at a rapid rule-out algorithm to diagnose acute MI within 1 hour. And they found that it's safe based on a high-sensitivity troponin assay. How do you see the use of high-sensitivity troponins evolving in the United States?
Well, first of all, when patients present, I'm in favor of taking a history, and I have to put that in at every point because we tend to think, okay, chest pain, do something, make a decision. We don't need doctors for that. So, but there are many patients admitted to emergency rooms where there's a problem, and we went through a whole phase of doing CT angiograms on these patients, and we still do to rule out the fact of an acute event. I think the idea, this is very encouraging to me that the high sensitivity troponin looks, pretty accurate here, not in ruling out coronary disease, but ruling out the fact that this is an acute infarction that has to be admitted. So it really is changing the patient from an immediate admission to the hospital to an outpatient evaluation. So I think taken in the context of the workup of the patient, this is helpful. How will it play in the United States? I think emergency room physicians are always looking for, an aid in the busy care patient so they can go sew up the next patient or take care of the other thing that is an acute emergency. And the chest pain, if they know it's not an evolving acute infarction, that's going to be very helpful. So I think this will work well if and when this test is approved, because somebody has to pay for these tests. And currently you tell me it's not approved, so that's a limitation, but sounds exciting, yeah.
Would there be any limitations?
The limitation will be, is it going to be paid for? The other limitation is, in terms of using that exclusively, there will be institutions that want to go further and characterize the patient. Okay, say it's negative. Then they're going to say, well, yeah, but this is a patient appropriately who we'd like to know more about. So a CT angiogram may augment that. But all this can be done without admission to the hospital. Some patients, quite frankly, don't need either one. They come in, they give a story. The story is clearly not cardiac related, and they ought to be dismissed. The idea of decreasing the number of patients, people who are converted to patients who shouldn't be patients is something that I'm in favor of. But this test will stand the test of time if it can reliably rule out people who need to be admitted, and we can depend on that. And that's the strength of this, the negative identification of patients as an acute event. Now, that patient may go out and have an acute event the next day, and the fact that they had that test, it's not the end of the story. So this will be very important for people using this kind of thing to not use it to rule out heart disease, but to rule out the need for an immediate admission to the hospital.
Got it. Great. The next trial I want to talk about is the FAME trial, something that pretty much everyone now knows about, but this is an update, as you know, at 5 years, FFR versus angiography in PCI patients with multivessel disease. So the study authors say that FFR should be standard of care now. Are there any exceptions to this, though?
Well, I'm a big fan of FFR. This FAME trial was disruptive to practice, and it changed the way we view things. We said we should be treating the lesions that need treating and not treating the lesions that don't. And the 5-year outcome of FAME is supportive of the original findings. That is, there was not only were there less stents placed, but the mortality is lower, and all the events were lower. And that happened in the first couple of years. But the important thing is there's no catch-up. During the next 3 years, the curves stayed apart. So this means that this was a good idea. I think that there's one caution That is, as we become so addicted to the FAME results as being valuable and telling us if a lesion is indeed producing ischemia right now, we might get overly addicted to it. So we got patients with angina, they have a negative FFR. It doesn't necessarily mean that's the whole end of the story. We're learning more and more about the microcirculation, we're learning about coronary vasoreactivity and things that might, so putting the FAME results in the overall context of the patient is very helpful, and using it to help guide revascularization, extremely helpful, but it doesn't end the story of evaluation of the patient with stable ischemic heart disease.
And the last trial is one of the first hotline session trials. It was one of 3 in that session actually that failed to meet their primary endpoint, the PROMPT study. They looked at peri-infarct zone pacing in patients with very large MIs. What can we learn from negative trials like this?
A lot, because, okay, there was a hypothesis, it was a reasonable hypothesis. Infarction many times results in abnormal wall stress, excessive wall stress around the infarction, peri-infarction zone. Maybe if you pace, you keep the ventricle smaller, the healing occurs in a way that you don't have so much dilatation of the ventricle, fine. But before you do that, you need to test it in a randomized fashion. They did that. They could not show any improvement in these parameters the way we do pacing now. And so the pacing in this trial was unipolar or bipolar pacing. It's not exactly, it's defined as peri-infarct pacing, but I mean we have no technology to specifically pace around the pericardium. But so this I think was extremely valuable. The value of negative trials is underappreciated, but it's just as valuable to find out what we shouldn't be doing as it is to find out what we should be doing.
Right, very well said. Thanks so much for being with us.
Thank you.
That concludes our talk here with Dr. King at ESC 2015. Thanks for watching.